right, everyone. We are nothing if not prompt here at Brady, and this is our lane. So I want to thank you all so very much for joining us this evening, or still late afternoon, depending on where in the US you're calling in from. As folks hop in, we're going to go ahead and get started. I want to kick us off by introducing myself. I'm JJ Janflone. I am the Culture and Public Health Partnerships Manager here at Brady, where one of the things I have the honor of working on is This Is Our Lane, which is our medical providers to the front advocacy and educational arm here at Brady. I want to thank our distinguished panelists so much for joining us all here. We have a really, I think, intriguing and important event planned tonight as we run through a variety of really essential questions. I've put everyone on this panel in an awkward position in that they are all brilliant, and yet they are going to have to limit their comments to very, very short snippets. What we're talking about tonight is the state of firearm injury prevention research in the United States today as it stands. As I assume you know, if you're joining this call, gun violence is now the leading cause of death among American children and teenagers. This has been the case now for a few years, and injuries overall are the leading cause of death for people under 40. I also want to recognize that some of the folks we have as panelists this evening, or that I know who are attending, are themselves survivors of firearms injury or have lost someone close to them due to firearms injury, which is part of kind of what we're going to be digging into tonight. So as a little bit of history lesson, after more than 2 decades of federal silence following the 1996 Dickey Amendment, organizations like Brady fought back, and Congress in 2019 restored funding for firearms injury prevention for the first time. It was a mere, seems odd to call it modest, but $25 million per year split between the CDC and NIH. But as everyone on this call knows who does research, $25 million for research period across the US is not nearly enough to fund what needs to be done. This investment, though, nevertheless jump-started progress. It got us new data systems. It got us new community-based violence intervention programs that have been incredibly effective. It led to suicide prevention studies. It led to evidence-based firearm safety initiatives. It led to kind of new and novel interventions. And overall, it saved lives. But today we know that that progress is under serious threat. The budget, the president's fiscal year for 2026 budget, eliminates all funding for gun violence prevention research, and the House Appropriations Bill, which we're going back and forth right now on, goes even further with a ban of GVP research. So we're going to break down today what's at stake. I'm going to start by introducing our wonderful panelists and then kick it over directly to them. As I'm introducing them and as we're discussing, if you have any questions, comments, or concerns as audience members, you have 2 options. One, you can click on that Q&A button at the bottom of your screen and post your question. Or if you'd feel more comfortable, you can send it directly to me via the chat function here on Zoom. I do ask that you be aware that all of our panelists here today are sharing their expertise based on themselves as subject matter experts and folks who have been working in this field for some time. They are not those speaking for their sending institutions or affiliated organizations unless they state so explicitly in their commentary. So to kick things off, we've got Dr. Joseph Sakran. He's Brady's board chair and chief medical officer. He's also the founder of This Is Our Lane. A survivor of gun violence, he now serves as a trauma surgeon and a leader at Johns Hopkins, where he advocates nationally for firearm injury prevention. He also is good with coffee, so if you need a pick-me-up right now, ask him which one you should get. Dr. Mike Anestis is a clinical psychologist and executive director of the New Jersey Gun Violence Research Center at Rutgers. His work focuses on suicide prevention, especially among military and veteran communities. He has an amazing study that every year I get updates on when I go to the national convention. I'm always very excited about that. Dr. Joseph Richardson is a professor of the University of Maryland and co-director of the Progress Initiative. He leads community-based research on gun violence prevention in DC and is an award-winning filmmaker and member of the National Academy of Medicine. And if you do not follow him on social media, you really should, because some of the narrative work coming out of his center is phenomenal. Dr. Emmy Betz is an emergency physician and professor at the University of Colorado, where she directs the Firearm Injury Prevention Initiative. She's a national expert in firearm and suicide prevention, and a member of the National Academy of Medicine. And I have told students before looking for work that if you want to know about gun owner attitudes, Dr. Betz is the person to go see at the University of Colorado. And last but certainly not least, Dr. Fabiola Plaza is a child neurology resident at Columbia University. She's a passionate advocate for health equity and gun violence prevention. She was recognized in medical school for her commitment to social justice and community engagement. And Dr. Plaza has been working in the gun violence prevention field for quite some time, even starting as a youth advocate in her undergrad years. So I want to start with a question for the entire panel here, which is, since federal funding for firearm injury prevention was restored in 2019, the night that it was, actually, I did a podcast with Dr. Sakran. We toasted. We had a little IPA on the floor of the Brady offices. What measurable progress have we seen in terms of new data systems, in terms of peer-reviewed research or intervention development? You know, if you can summarize really quickly, what is one thing that we know now that we didn't in 2019 because of these funding sources? And I'll let y'all duke it out. Looks like Dr. Sakran's hitting it first.
Okay, but yeah, I'll just kick it off. And it's great to be here with everyone. I can definitely give you some tips on coffee. So just, hit me up offline, but I will hopefully be able to give you some thoughts around firearm prevention tonight. And I just want to start by saying I'm honored to be joined by this incredible panel. And JJ, thanks for putting this together. We're really delving into, I think, a super critical issue. And I'm sure a lot of the people on this call obviously agree with that, which is why they're here. So unfortunately, we're a little bit, preaching to the choir, but I think for far too long, we all recognize that this field has been under-resourced. And I think, the appropriations for key institutions like the CDC and NIH are really, facing potential threats. And I think since federal funding for firearm injury prevention was restored in 2019, we have begun to see real measurable progress in systems, in science, and early intervention work. And that was largely, absent before. I think, as we think about, here's what we know now and that we could not before, I really kind of think about it in a couple of different ways. One is this like surge in funding, trials, and publications. So there was a piece in 2024 done by JAMA Surgery, and this analysis essentially showed that federal funding, registered clinical trials, and peer review publications in firearm injury prevention all rose sharply since appropriations resumed. And in particular, from 2020 to 2022, the number of registered clinical trials grew 90%, and publications rose 86% relative to 2017 to 2019. I could also, go on to say that, when you look at what the CDC has done, the CDC had reported that since it resumed awarding firearm-related research grants in 2020, it has supported 34 projects to date. And I think that these trends reflect not just more money, but increased legitimacy for the field and new investigators entering it. There's a lot of other things that we can go into, like strengthening data infrastructure, early intervention development, and pilot trials. But I want to give space for my colleagues on the call to kind of chime in on some of those.
Yeah, thanks, Joe. I'll jump in too. I'm not quite as caffeinated, but it's earlier in the day in Denver, so I'm still awake. I was reading the same JAMA paper today and thinking about sort of how to describe what's happened. And I actually want to use some personal stories, if I can, to like take this to the micro level. Back in 2018, when there wasn't really a lot of funding, we were using bits and pieces of institutional funding or doing unfunded projects. And that's when we built the first out-of-home storage map in Colorado as this idea, like maybe this would help people who need to temporarily store a gun away from home and don't want to involve police, but how do you do that? So it was really like a summer project as this by a student. Got a lot of interest, including from folks like Dr. Anestis, which we were really excited about the sort of concept, but nobody really knew, would it work? Would people use it? Like what did it look like? My lab then was very lucky to get some of the initial funding from that first round from NIH in 2020. We were able to do a multi-site study, engaging with firearm businesses, with firearm owners, really exploring what do people want, what makes sense, what are the barriers. Findings from that work led directly to policy changes in some states around protecting firearm dealers from liability for storage and so forth. And then that NIH funding subsequently laid the groundwork for now a DoD funded project that's we're working directly with retailers surrounding military bases in 10 states with a nationwide storage map. And I don't think any of this could have happened without that funding, because we were all just sort of making guesses in the dark about what we thought might work. We were doing what we could, but you need a larger scale investment to really be able to engage communities ethically and appropriately and really understand what people on the ground are needing, to then be able to build the programs that, like, we think now are directly supporting military families. You can't do that without the funding piece. And I think that's just one example from our institutions, and there are examples like that across the country, including from other folks on this call. And it wouldn't have been possible without the infusion of funding, even if it wasn't enough. But we're going to go backwards if we don't keep the funding up.
So I'll hop in. I definitely think that the trickle down effects of the funding led to the expansion of more philanthropic investment. And so while we may not have benefited from that $25 million, I think private philanthropy realized that we would not. And as a result, expanded investment dollars. And so since that time, we've had significant investment. For example, I serve as one of the senior fellows for the Black and Brown Collective for Community Solutions to Gun Violence. And we know that scholars of color were least likely to get NIH and CDC funding. And so private philanthropy stepped up in that way. And now the collective, through private philanthropy and grant funding, have well over $6 million of funding to train early career scholars of color. The research for the Society for Prevention of Firearm-Related Harms, which some of us on this call are members of, and members of the board, was expanded during that time. And we just saw a significant, explosion in terms of state offices of gun violence prevention in Maryland and in New Jersey, as well as states across the country, and an investment in offices of gun violence prevention nationally. So I would just say, not only did the reinvestment in the CDC and the NIH open the doors for gun violence researchers on a federal level, but I believe it actually sparked more investment in just gun violence research from the private sector.
I can jump in. The folks said a lot of great things already. The couple of points I put out. One, I think we realized with the federal funding just how hungry people were to make this a bigger field. And not just in the sense of the obvious answer, which is now you can fund young researchers to enter it, but a lot of those numbers that Dr. Sakran cited earlier about the numbers of clinical trials and number of publications, those came from established folks who hadn't been in this space, but maybe came into the space because there was funding now, right? So it shows that there's an ability to grow this field and make huge contributions. Sorry, a little distraction. Make huge contributions from a larger number of folks who would not have otherwise been a part of this. That's the first thing I learned. The second thing I'd add in is just that, excuse me, it's not, the partisan nature of research funding is obvious. There's battles about politicizing, does this get funded, but the research itself is clearly nonpartisan. And I think Dr. Betz's work is a great example of this, is that as the federal government is invested in this, you've seen communities from all different political stripes going all in on this work and collaborating. And that shows how scalable a lot of this stuff is. There's an ability to make massive impact that wasn't necessarily obvious when we didn't have the financial backing to actually build those studies and build those collaborations the way they've been built over the last handful of years.
I think the only thing that I would like to add is the fact that all this federal funding is coming in gives legitimizes the issue. And just as the other people in this call have been saying, it really brings attention to the fact that this is a major public health issue. And now we have these statistics that we're able to say, for example, how the statistic of how gun violence is the #1 leading cause of death in pediatric patients, that is coming from research over the last couple of years. We now know about the large disparities that exist within gun violence and gun violence related deaths, especially in Latino and Black youth. And I think that also mobilizes a lot of people of color to also become involved in this issue, just like seeing how large the disparities that exist are and how we can get involved as communities of color to really rally behind this issue and to really call attention to this issue. And so I think that's something that brought me into the field. And I really appreciate what Dr. Anestis said about how this funding brings young researchers into the field, because before, I remember I graduated undergrad in 2019. And so this is before all of this. And it was, I remember coming up with some ideas and being told like, oh, that would never get funded. But now it's, there's a possibility, there's a chance.
And I would, if anyone on this call is kind of curious about what that looks like, go to Google Scholar and just type in gun violence and do a sort by date and see the kind of explosion of papers that are coming out, in late 2019, early 2020 of like really phenomenal work. And I appreciate the flag, Dr. Anestis, that in some cases by young scholars and in some cases by folks who had been doing kind of adjacent work for a really long time, but had to be very careful about the way they phrased maybe their gun violence work or their mortality studies. And then now we're kind of able to go fully into it. For you, Dr. Sakran, I'm curious, when we're talking about things like CDC and NIH investment, I'm wondering if you can kind of break it down for folks who maybe are not in the medical field on this call. How did the building or the funding of infrastructure related to that, how did that assist in terms of like real world clinical settings? So like, how did us seeing like CDC and NIH funding suddenly be present? How did that maybe help in kind of the day-to-day work of someone who maybe is in a research institution or actually at a medical center?
Yeah, thanks, JJ. I think it's a good question. I mean, essentially, when we think about the funds and how they catalyze, I guess what I'll call like the development of infrastructure networks and pipelines that were previously underdeveloped, I think you could think about things like the fact that appropriations that were made were not just necessarily for single studies, right? You had, RFAs, right? Requests for applications that encouraged infrastructure, partnership, and sustained capacity. Maybe that looked like data linkages. Maybe it looked like measurement validation. Maybe it was interdisciplinary consortia. So I think that's, a piece that's really important to remember. RFAs can come in kind of different flavors. I think the other thing is like, we saw how, as an example, hospital-based violence intervention programs, where hospitals were increasingly kind of embedding these programs that identify patients at highest risk for repeat violent injury, and then connect them with the wraparound services, the long-term case management, the mentorship, employment, mental health, and so forth. And although these HVIPs predate the revived, kind of funding, I think the federal support really helped scale and standardize and honestly rigorously evaluate a lot of them. And data and evaluation capacity really became part of that infrastructure. I think to the point that, my friend Dr. Richardson made, the philanthropy came along with that, right? It wasn't just, I think people, and maybe Dr. Anestis, you're also have been talking about this. It's like really trying to think about, how do all of us across sector really take a part in being part of the solution? Whether it's the federal funding, but also like businesses and public health departments and health systems and education, all of the different components have come together in a really kind of fascinating way. The other thing that I'll say, and again, would love to hear thoughts from my colleagues, but really, as we think about training pipelines and interdisciplinary folks and how we've really tried to secure more funding that really, I think, comes with legitimacy for universities to commit faculty time, support, whether you're a PhD or a postdoc, and really kind of do things like embedding firearm prevention modules across public health and medical systems, and how we're training our medical students and our residents. So all of this is interconnected. And I think these evolving networks, hospital, community, academic, public health systems, begin to produce durable capacity rather than one-off projects, if that makes sense.
No, I mean, I think it makes perfect sense. And I think it ties in really well to the next question I had, which was actually for Dr. Anestis, which is to kind of bookend that. Do you have any specific examples of like evidence-based tools for reducing firearm injury and death that have resulted from this federal funding? So whether it's in things like suicide prevention or clinical practice, whether it's through like the establishment of these pipelines, how do we kind of go from point A to point B in part because of this funding?
Yeah, and it's important to remember from the suicide prevention perspective, which is what I'll really speak to because that's where my expertise is. There's folks in these calls who know so much more about community violence than I ever will. So I'll speak to that side of things. It's a little bit of a slow ride to go from investment to tool to reduction in deaths because of the base rate of these behaviors and the way that they show up. But what I've seen over the last handful of years is a number of really useful tools across different settings come out of federally funded grant. So for instance, earlier we were talking about this secure firearm storage maps, out of home maps. Those have expanded both in terms of their scope, but also the knowledge about them and what does and doesn't work about them. And so this becomes a very useful tool for folks in the community in moments of need to be able to look and find a local resource to save their own or someone else's life. That comes from federal funding. You see tools that are embedded within healthcare systems. So there's the great work of Emmy Betz on firearms screening across healthcare systems. That was, I've seen some absolutely massive, incredible data sets that she's presented on from her federally funded work. That's astounding how much she's gotten practitioners to take part in these things. You have Emmy's work on Lock to Live that we talk about all the time, which is a app-based tool for secure firearm storage. Folks can do autonomously in an ER setting. So it takes demand off of healthcare providers. It creates privacy for folks who maybe don't want to talk about their situation with the healthcare provider, but to nonetheless engage with life-saving material. Within our own shop, we had DoD funding for lethal means counseling and intervention called Project Safeguard, where we worked with folks in the Mississippi National Guard. And with more federal funding, again, in collaboration with our friends in Colorado and on Ohio State, now Vermont, we have changed that intervention and adapted it and implemented it, and then leveraged that into foundation funding, like Dr. Richardson was talking about before, to now be able to roll that intervention out across the entire National Guard. And so across the last 4 months, that tool that came out of federal funding has now resulted in us not only training thousands of folks in the National Guard in lethal means counseling, but providing every single attendee, over 1,000 of them now, with biometric lock boxes for their firearms, right? And so all of that comes from those investments a few years ago. And there's a lot more to come, right? I think people have to have some patience. The unfortunate pace of science sometimes makes it hard to translate what we do into the impact in people's day-to-day life. And that makes us targets, which is why this conversation is happening today. But I think a lot has been developed on this front.
I do want to let panelists know, please feel free. You're welcome to jump in. You don't have to wait for me. I know that all of you could be in conversation forever. Because I think this ties into, even Dr. Betz, some of the work that you've mentioned kind of earlier on this call, when we're talking about things like the screening, the counseling, the hospital violence intervention programs, HVIPs, and even things like kind of the community involvement. So being able to access maps and use those. Can you talk maybe a little bit more about how the infrastructure that was developed with this funding, how it supported hospitals and communities? Dr. Anestis gave us a little bit of taste of that, but what processes are there that maybe weren't there prior to 2019?
Yeah, and I think maybe I'll at the same time answer like what we worry about if there are abrupt cliffs in funding.
Yes,
sort of how we think about building systems. I think, and I know all the folks on this call know this, but if some listening may not, when we think about science, it's not like a easy on, easy off kind of a thing. Maybe it's easy to turn off, but I think about there's sort of two pieces. There's like the infrastructure and the processes. So to do any kind of robust study that is appropriately engaging communities or stakeholders or whoever needs to be, like there's a lot of planning and standard operating procedures and staff that you have to hire and making sure you're complying with ethical and legal requirements. And there's a lot of sort of preparation time before you even get to the point of potentially enrolling participants. And even that piece, like even getting the gift cards or whatever the processes are, like that takes time. And so that's part of the reason why big studies are usually multiple years long, is because it takes that, not just to do the study and enroll the people, but like just to build the system. But then the person part of it is really important too, because obviously science doesn't just happen. There's like the lead investigator, but it's actually one of the many things I love about science is it's a huge team effort of multiple investigators, sometimes from different institutions, but also students and professional staff and statisticians and budget experts, everybody sort of working together. And so I think one of what we saw happen, for example, when I was talking earlier about some of the early NIH funding we got, with that funding, we were able to support a graduate student, for example. So she worked as an assistant on the study, was able to finish her graduate degree, and then was able to take a faculty position. That's an amazing way to engage sort of a trainee in the process of something. What we're all, I think, particularly worried about right now is with a drop in funding, positions for graduate students, positions for postdocs become really uncertain. And if you are in a graduate program that's 5 years of your life or more, and with tuition demands and not a lot of salary, that's someone's life that you're asking them to sort of put at risk. And so it becomes harder to attract top quality early scientists. And some of the phenomenal staff we have at our universities, lifelong research assistants, program managers, budget specialists, statisticians, and so forth, potentially get reassigned to other projects or even leave the field because there's no certainty in funding for them. And that is really, really hard to replace and rebuild. And so, I think what I've seen in our own institution and at others in the space where we've had this incredible federal funding augmented with foundation funding is we've been able to build these wonderful teams from senior to junior, as well as all this sort of supporting close community partnerships. And when funding disappears and infrastructure disappears and people disappear, it sort of scatters and it's really hard to rebuild. And that's what I lie awake worrying about at night. Not so much me and what's going to happen to me, but what's going to happen to all these trainees and earlier career folks or full-time staff that we have.
And that's a great flag too, because I think there's a large misconception about what the process of science is. So why can't we just fix gun violence with 25 million for 1 year? And that I think it's an image of science is Dr. Frankenstein in his lab by himself. Maybe there's Igor and that's it. That it's a very small, quiet process when that is not the case at all, as you've pointed out.
JJ,
and to that end,
can I just chime in real quick? Because I think Dr. Betz's point is so important. Like, it is so easy to essentially destroy a program, to disassemble it in such a quick way, but to rebuild it. And as I think about like where we are even now and what it took to get here, that takes a much longer time. And I think that's part of, I think, the anxiety that a lot of us, are feeling and seeing, outside of course, not wanting to have those postdocs that don't know what they're going to do, or having our budget people or statisticians pulled. It's like that, like, destruction can happen essentially overnight. I mean, I'm maybe exaggerating a little bit, but to rebuild it will take years, if not longer. And that's, I think really sad, especially considering how I think a lot of us here on the call and the people that are doing this work really have tried to take a data-driven, thoughtful approach to figuring out how can we put, solutions out there that we know are going to save lives.
And that's my question for you, Dr. Richardson, because I know you do so much work with so many different partners across a variety of institutions. So how do these funding fluctuations, whether it's a slowdown to a trickle or a complete stop, how does that impede, like community-engaged interventions, interdisciplinary collaborations that I know you've spent far more than the last 5 years building? But how does this maybe even affect trust and partnerships with local organizations or the community that we're kind of planning on having sustained engagement?
So it's totally affected community violence intervention, and quite frankly, I don't think people understand the magnitude of how many lives that it has affected who are employed on the front line. And so I'm leading the evaluation, as you mentioned very early on, with Daniel Webster of CVI in DC and Street Outreach. We have 2 CVI programs, at least over since 2018 we had one under the Office of the Attorney General, which used the CURE model, and then a second program under the Mayor's office, under the Office of Neighborhood Safety and Engagement. Now, due to this funding crisis that we've recently experienced, our 2 programs have merged, but the result of that is that the CURE program under our Office of the Attorney General no longer exists as of October the 1st. We had 10 sites around the city in neighborhoods where we had the highest rates of gun violence where they started their program. They're now down to 6, and those 4 were eliminated were in neighborhoods where they were able to significantly reduce gun violence. So you have to think about all of the people who were frontline, and let's be quite frank, many people who are on the front line could easily be a program participant on any given day. And so now we've lost a significant number of people in the workforce who relied on those jobs, and they weren't paying a lot of money either. They were paying roughly $55,000 a year in the most rapidly gentrifying city in the United States that has the highest rent that you could ever imagine, right? And so now these people are no longer working in communities where they establish trust. And I'll just give you an example. I met with a site last week that's under the CURE model, under OAG, which recently merged into the Mayor's program. They had to cut their violence interrupters, the people who actually do the work on the ground, down to 2 violence interrupters to cover two large neighborhoods in DC. There was a third neighborhood where they totally eliminated the site and are now asking those 2 VIs to cover 3 neighborhoods. I just want you to put that into perspective. We're talking about easily 100 blocks. It's impossible. It's basically a setup for failure. And so when you're asking VIs who typically are from the neighborhoods, work in the neighborhoods where they were born and raised, to then going into another neighborhood that would recently eliminated a VI program, that totally erodes the trust of the participants that they were working with. And not only that, the 2 people that now have to go into that neighborhood, they don't have ties to those neighborhoods because they were not born and raised there. And that impacts the effectiveness of the program. And so we're now moving to a ward-based approach where we're asking more for less. You have fewer staff that are asked to cover more territory, which then again impacts trust and trust building, because VIs are expected to engage in violence intervention in the communities where they were born and raised. And just to really put this last thing into context, this is actually happening in real time. 5 minutes into this call, I just received a text from one of my site directors who his program was cut on October 1st. And maybe a week ago, I went out to the field to visit his site, and they often set up in row homes. His site was closed, and his site 2 blocks down the street was closed. He just texted me while we were on this call to let me know that they had to fight to get their money back, and they were just awarded their funds. But this is what we're going through in DC, right? It's a very real experience for people who are responsible in part for what we're seeing in the declines in violence, not only in Washington, D.C., but in Baltimore and cities across the country that have experienced significant declines. That's not just attributable to law enforcement. That's also from the investment in people who are doing the work, who now, because of these significant cuts in gun violence prevention efforts, no longer have employment.
We had a question come through that I think is great. So I'm gonna jump and throw it in before we get to the Q&A portion right now, which is, for folks on this call who may not be kind of familiar with the way that some of these projects work in science. So Dr. Richardson, you mentioned that, the outcomes are going to probably be lesser because there's less folks there. How can, when you've had to reduce a study, either in sites, a number of participants, and kind of scope, how can that affect future funding? And I think I want to throw that out to everyone out here on the call. So when before maybe you had 8 hospital systems, now you have 4. Before, when you were maybe studying over the course of 5 years, now you only have 2. How might that impact your ability to judge if something is useful or not? Anyone want to jump in?
So in the CVI work, I would just say you begin to see effects 3 to 5 years. So if we're only funded for 2 to 3 years, the lag effect of actually determining whether this intervention had a significant impact on the outcomes, we may not be able to assess that, particularly for new startup programs, right? So I would definitely say the sample size would get smaller. And also want to acknowledge there's a significant difference in the methodology too, right? As a qualitative researcher, I have to go out into the field and establish those relationships of trust, which may take a year of investment in just establishing the relationship before I begin to collect data. So if we're working with 2 to 3 years of funding from a qualitative perspective, the robustness of the data will be affected without question.
Yeah, I agree. I don't have much more to add. I think Dr. Richardson, as always, sums it up nicely. Reduced statistical power, decreased, generalizability, right? And then that kind of lends into external validity. And I think, obviously, increased susceptibility to kind of random variation when you have those kind of impact of reduction and so forth. And then, limited kind of ability to, some of these big studies that we do, we have different subgroup effects that we look at. So I think all of those, make a lot.
Yeah, I would love to just add on also I think the question was also about the likelihood of future funding. And the problem is that when relationships and programs are destroyed or cease to exist, it's harder to get future funding because understandably, like big federal grants are usually not to get the relationship in place. Like they want you to be able to hit the ground running to do the scientific study. And so if all of the frontline workers have been fired, or if the program on the ground is no longer functioning, or if researchers and et cetera, have quit, like it becomes that much harder then to get the subsequent funding because you have to rebuild all of the foundational pieces that you need in place to be able to do the work. And I think that's what's frustrating about this on a global scale too, separate from the sort of human impact of people losing their employment, is it's just such a waste of money. I mean, when we cut things off prematurely, or we don't allow programs to sort of carry on and finish what the plan was, the money you've invested in the study, like you're left without strong results from it. And in that sense, it feels like a waste of resources as well, which I think all of us on this call think carefully about when we have federal funding, that it is taxpayer investment in research and you want to be using it wisely. And so it's separate from the human perspective, like just really frustrating as a scientist when you feel like that you haven't been able to do that perhaps.
Yeah, I echo that last point that Emmy just said, which is I think all of us feel a pretty heavy burden when we have some funding for gun violence research because there's been so little. So it feels really important to land the ship when you do it. And so anything that disrupts that, I think we all take it very personally. But I think another thing I'd add also is just that I mentioned earlier about scientists being easy targets for types of behaviors that initiated this webinar in the first place. And I think when our projects get sort of cut off partway through, even though we didn't decide to cut it off, I think we wear that, right? We're the face of that disruption, and that makes us look unreliable, and it makes us look less likely to contribute to the daily needs of people's lives. And so then when people want to paint scientists as not a good investment and science as a waste of time, well, just look what happened here. Everything fell apart. Now, why did it fall apart? Well, because someone pulled the funding away, but nobody listens long enough to hear that, right? It's just that we didn't land the ship. And so I think this is another way to delegitimize the work of folks who might otherwise legitimize solutions that folks maybe don't have an appetite for who are pulling financial levers.
And kind of this is on the frustration end as well. So Dr. Plaza, I know for you, some of the work that you've been doing around making sure that you're integrating like firearm safety and firearm safety training through things like This Is Our Lane, How to Talk to Patients About Firearm Safety Guide and things like that. When there's these pauses in medical education and things, what are you seeing both as a doctor and as a resident in training within kind of hospital systems or kind of these changes to patient care? And are you feeling sort of the same frustration?
I'm definitely feeling the same kind of frustration, just because as someone who has been personally affected by gun violence, it's sad to see my peers not really learn about it or learn about the dangers, especially as I mentioned, I'm in child neurology residency. I'm in residency in pediatrics. Like we've said, you know, guns are the #1 killer of children, and it's a very huge safety issue for our children. And the fact that there was a survey that showed that the majority of pediatric trainees don't get any type of training of how to ask about gun violence, how to ask about guns in the household, how to ask, like, do you have a gun? And it's in my experience as well, even if we were to train, like, okay, ask the question, a lot of people don't know what resources to even point to, because there's that loss of funding that then loses these institutions that then are helpful resources that we can go to. And so it's frustrating because, like, we don't know to ask the question, and then if we were to ask the question, we don't even know what to do with the answer. And I'm in New York City too, and so it's not I think people are not so aware of like how gun violence is such a huge problem in New York City, just because they assume that things are okay. And so it's really the lack of knowledge that is really frustrating for me.
And I kind of want to, in the time that we have left before we open it up for Q&A, and so everyone in the audience, make sure you're sending your questions in. I have a few that I kind of want to open it up to the full panel. I think we can engage in kind of conversation around these, which is the first one being is, you've all touched on this in some way, but what are the broader societal costs of underfunding firearm injury prevention, given the scale of this epidemic, the fact that we've acknowledged it, the Surgeon General came out and said that this was an epidemic. What message does it send, not just to, you know, communities and survivors, but also to scientists and practitioners, folks that are either new in their career or folks who have been doing this for decades, you know, for this funding to either be limited or for it to go away? What is the actual cost of this beyond the money portion? What does this do?
I think it implies that we just have to live with it and that it's not preventable.